in.
Good afternoon or good morning, and welcome. We're truly delighted to have you with us today. My name is Tamar Chalitze. I'm a disease area partner here at Roche Diagnostics, and I'll be moderating this discussion. Today, we bring to you the second and the final session of our two-part webinar series that is hosted in collaboration with National Coalition of STD Directors, NCSD, and Roche Diagnostics. Across this series, we've been exploring how the latest innovations in testing are reshaping STI care and what these changes mean really both for providers as well as for the patients. And before we move on to the presentation and the session, I want to pause and recognize our partner, NCSD. This collaboration has been invaluable for us, and we're truly grateful for this partnership. And a very special shout out to Leonardo Parker for his exceptional leadership and partnership in bringing this series into the life. And to start, I'm actually pleased to welcome now Leonardo Parker from NCSD to share today's housekeeping items. So Leo, the floor is yours.
Thank you so much, Tamar. Good afternoon, everyone. I am Leo Parker, Director of Prevention here at NCSD, and I'm going to be serving as your tech today. So just want to run through a couple of housekeepings just to ensure that we make sure that today's webinar runs smoothly. If you will, please keep yourself on mute at all times. This will allow ourselves the opportunity to hear our speakers clearly and concisely. If you have any questions, please put them in the Q&A box, not the chat. We will reserve the chat box for any comments. We will take all questions at the end of today's presentation. So just please hold those questions until then. As a reminder that this session is recorded and it will be available afterwards on the NCSD website and in our Learning Center, along with the slides from today. Lastly, if you have any questions or any technical issues, please feel free to send me a direct message in the chat, or you can shoot me an email at lparker@ncsd.dc.org. And then for best experience, so that you can make sure that you see your speakers, feel free to switch your view to speaker view. Thank you for all of that. And if you have any questions, just let me know, and I will turn it back over to Tamar.
Thank you so much, Leo. Now I'm delighted to introduce our speakers. First speaker is Dr. Megan Crumpler. She is the Laboratory Director at the Orange County Public Health Laboratory. She has a PhD in microbiology and immunology, is board certified as high complexity clinical lab director, and is also the immediate past president of APHL, where she co-chairs the HIV, viral hepatitis, and STI subcommittee. Our next speaker is Dr. Kenneth Mayer, a leading authority in HIV and STI research. He serves as the founding medical research director at Fenway Health, is a professor at Harvard, and infectious diseases physician at Beth Israel. Also, he's an editor-in-chief of Journal of International AIDS Society. So with their exceptional experience and expertise, Doctors Crumpler and Mayer will help us to identify current gaps in STI diagnostics across different care settings, highlight new technologies that can close those gaps, and share strategies for bringing this innovation into practice. So quick disclosure here, I'm an employee of Roche Diagnostics in non-commercial medical and scientific affairs. Dr. Mayers and Dr. Crumpler are invited speakers through NCSD, and this session is supported by Roche Diagnostics non-commercial division, and the views expressed today are those of the presenters. So now, actually, I would like to set the stage for today's conversation and how it really connects to the overall series. As I mentioned very briefly, though, earlier, this webinar is part of our two-part series on advancing STI diagnostics with the focus on expanding access and meeting emerging needs. Today, as you see on the screen, is a part two, future-proofing STI care, meeting emerging needs with diagnostic innovation. To give you a little bit of a picture, full picture here. So part one of this series was beyond the clinical walls, unlocking the full potential of molecular point of care testing. across diverse settings. This webinar was held on September 9th. During that session, Dr. Southern and Ms. Brady shared how one from the laboratory and the other, the clinician point of view. Ms. Brady showed how molecular point of care be scaled across labs, correctional facilities, shelters, and rural clinics, covering topics from CLIA waivers and data integration to workforce training, outbreak response, and sustainability. If you missed it, the recording is available on demand through the NCSD site. And I think, Leo, you mentioned that you maybe you already did, sharing the link with the audience. Okay, so turning now to the context, agenda, and objectives for today. So first, why does this session really matter? STI rates remain high. We're all aware of this, and we know there are still quite a bit of blind spots that can delay care. But the exciting news why we're here today is that new molecular point of care innovations are emerging to help close many of those gaps. Aligning labs, clinicians, and public health is the key to future-proofing the care. Here is the agenda. We will start with the two presentations, and I introduced the speakers already, and then we move into the moderated Q&A section. So please feel free to submit your question in Q&A box, but I will encourage everyone to do so even throughout not to wait until the end of the presentation, but you can submit the question throughout. So we have hopefully a pile of them, at the end of the discussion. And finally, our learning objectives are to identify current limitations in STI diagnostic capabilities across care settings, to explore emerging technologies that can address gaps in detection and treatment, and to understand strategies to support the adoption and integration of the new diagnostic tools. So with that context in mind, let's move into our first presentation. I'm very pleased to welcome Dr. Megan Crumpler, who will now take us through her talk. Dr. Crumpler, over to you.
Thank you very much, Tamar. Good morning, afternoon, wherever you're calling from, and thank you for joining today. I'd like to extend thanks to both NCSD and Roche for the opportunity to be here today. It is an honor to speak on a topic that is both timely and critical to public health, where we will be discussing laboratory innovation and addressing the diagnostic gaps in STI testing, with a particular focus on the role of laboratory testing. Like Tamar said, I'm Megan Crumpler, currently the director for the Orange County Public Health Laboratory. I'm excited to share insights from my work, explore current challenges, and discuss opportunities for innovation in this vital area of public health. Can you go back to the outline slide, please? Thank you. Today, we will be covering several key areas related to STI testing and public health laboratories. We will discuss the role that public health labs play in STI testing and surveillance, current limitations in STI diagnostics and where gaps still exist, preparing for what's next. We have an expanding role of molecular diagnostics and emerging molecular tools, how labs can get operationally ready for implementing these new tests, and how we can scale innovations through strategic public health collaborations. These topics are essential as we work towards more equitable, accessible, and effective STI solutions. So let's begin by looking at the foundational role that public health laboratories play in STI testing. Next slide, please. Public health laboratories are often the unsung heroes in disease detection and response. When it comes to STIs, our labs are not only testing centers, they're also surveillance hubs, innovation drivers, and critical partners in outbreak response. I'll start with answering a common question. What is a public health laboratory? Here, APHL produced a short video describing what public health labs do, and Tamar will play that video for us now. It's only a minute long.
Wonder who identifies health threats to keep your world safe and healthy? It's the laboratorians and public health laboratories across the country. As part of the public health system, these governmental labs work to keep your communities healthy, and they play a bigger role in your life than you may have guessed. Starting with newborn screenings that identify dangerous genetic and metabolic disorders that can cause disabilities or even death early enough to treat them. Laboratorians are disease detectives working tirelessly to prevent outbreaks by monitoring communities for pathogens that spread through contact with people or your environment, and testing to protect you from foodborne illnesses. Public health labs test drinking and some recreational water for bacteria, parasites, pesticides, and other harmful substances, all as a part of a coordinated health system effort to have fewer sick people and ultimately a more comfortable environment to live in. You may not have heard about them, but in one way or another, their work has affected your life and that of every American. Learn more about how public health laboratories protect your health at aphl.org.
Thank you, Tamar. And if you'd like to learn more, CDC recently released a Public Health Laboratories 101 course on their One Lab training platform that is available to everyone for free on their website. And these resources help summarize and share the important work that public health labs do every day to protect our communities. Next slide, please. Just elaborating kind of on the video, our core functions are playing a role in monitoring and responding to new and emerging infectious diseases, environmental health, emergency response, food safety, and newborn screening. This document here on the screen is available on the website, and it's used with legislators on Hill Day, policymakers, and other decision makers that may not be aware of the importance of public health labs. We often operate kind of in the background, but there are public health labs located in every state, shown in the map in the upper right-hand corner, and we play a critical role in protecting our communities. Next slide, please. APHL, the Association of Public Health Laboratories, is our national organization, and one of the roles is to provide resources for public health laboratories and the members. So they provide things like training modules and issue briefs, survey reports, which are shown here, some webinars, and so these resources are free to if you have an aphl.org account, and you can access these, and they're really meant to support laboratories in their everyday work, by promoting best practices and support for confusing or complicated topics. So these links will be available to you in the slides. Next slide, please. So I'll talk a little bit about my public health lab here in Southern California in Orange County and the testing that we perform. This testing is fairly representative of testing done by many public health laboratories, especially our local laboratories, because we are located in our communities and have a close link with them. So we serve a variety of clients, but when I talk about STI testing, our main clients are our HIV STI public health clinic. We have a extensive correctional health program within our county amongst our 5 county jails. And then we also serve community-based organization clinic sites. We perform the full gamut of STI testing, so HIV antibody screen. Our clinic is a PrEP testing or a PrEP site, so we perform testing for the clinic, syphilis, both the reverse algorithm as well as for treatment monitoring, CTGC, NAT, trichomonas NAT, hepatitis B surface antigen, and HSV VZV NAT. It's really important for public health labs to interact with our providers. We may play a role in outreach testing. For example, our STA program may perform screening testing in the field for HIV or syphilis, but then that specimen will come here to complete the full testing algorithm. Next slide, please. This is hot off the press data released last week. So it's a provisional report that CDC released of the 2024 STI infection or sexually transmitted infection surveillance. So in 2024, the combined total number of cases of chlamydia, gonorrhea, and syphilis declined 9% from 2023, which is exciting because this is down for a third consecutive year. But there were still more than 2.2 million reported STIs in 2024. And compared to a decade ago, the overall cases are about 13% higher. Some key highlights are that chlamydia cases declined for the second year in a row, down about 8% since 23. Gonorrhea cases declined for the third year, down 10% since 23. However, congenital syphilis increased for the 12th year in a row, with nearly 4,000 reported cases in 2024. We are seeing some decreases in primary and secondary syphilis cases, which have declined for a second year in a row, down 22%. And I was actually at a conference this week, and on Tuesday we had a speaker from the California Department of Public Health STI program, and she shared some of the recent California data as well, and said that it is really promising that primary and secondary syphilis cases are decreasing, and that typically congenital syphilis will lag behind a year or two. So we are seeing some progress, which is fantastic, and hopefully this continues. Next slide, please. Today, though I will be focusing on laboratory testing algorithms, point of care was covered in a previous session. So while we've made significant progress, there are still notable gaps in STI diagnostics. So we'll take a closer look at where some of these testing methods may fall short, and how they can affect patient care and public health action outcomes. Next slide. So as we look at the current landscape of STI diagnostics, it's clear that while we've made significant progress, there are still several critical limitations that impact both clinical care and public health outcomes. We lack widespread access to drug resistance testing, particularly for infections like gonorrhea and Mycoplasma genitalium. So this limits our ability to tailor treatment and may contribute to the growing threat of antimicrobial resistance. Second, many diagnostic platforms still don't offer dual claims for diagnostic and screening, or qualitative and quantitative, which means that we often may need to run separate tests or collect separate specimens, which can add time, cost, and complexity to the diagnostic testing process. Another challenge is the requirement for multiple specimen types to complete the full HCV and HIV or HCV testing algorithms, which just adds an additional barrier in both clinical and outreach settings, especially when we work with the populations that public health often serves, which may have limited access to care. There also are age-related limitations in testing. Many platforms are not cleared for use in younger populations. Some are 2 years old, some are 14 years old, despite the fact that adolescents and young adults are most affected by STIs. So many labs like our own have performed CLIA validation to expand the age groups which we can perform testing, because we do serve a juvenile hall as well as a women and children shelter where we receive STI specimens from. So we do need to test these populations. And importantly, many STIs are asymptomatic, which means individuals may not seek testing until complications arise and can unknowingly be transmitting infections to partners. When it comes to HIV and syphilis, the diagnostic algorithms can be complex and difficult to interpret, especially in low resource settings or when dealing with latent infections. And the increased use in PrEP, while a great medical advancement, can lead to or introduces new challenges in interpreting test results. For example, seroconversion for HIV may be delayed or atypical, and this can complicate diagnosis and follow-up. And we're seeing that as PrEP is more widely used. These limitations underscore the need for more integrated, accessible, and adaptable diagnostic tools. And on the next slide, I'm going to focus on some alternative specimen types, including extragenital and non-traditional sources. So one way that's being, pursued by many manufacturers is to expand access to STI testing is through the use of alternative specimen types. Traditionally, STI testing has relied on urogenital samples, but we know that extragenital sites like the rectum or the throat can harbor infections that would otherwise go undetected. So incorporating these into routine testing is essential, especially for high-risk populations. However, the FDA approval for extragenital specimens and testing has not kept pace with clinical needs. Many labs, like our own, are using laboratory developed tests or off-label specimen types, which can create regulatory and reimbursement challenges. So expanding the FDA cleared claims for these specimen types will continue to take us forward in standardizing care. We're also seeing innovation in serologic testing, particularly through the use of microtainers and dried blood spots, as shown here in the image on the slide. These methods are less invasive, they're easier to transport, and ideal for outreach settings or low resource settings, especially valuable for patients who are difficult to draw blood from, such as intravenous drug users, or infants, where traditional phlebotomy can be challenging. Microtainers allow for small volume blood collection, and dry blood spots offer a stable, low-cost option that doesn't require cold chain. So it makes it ideal for transport, for example, in the mail. However, due to the number of tests that may be ordered, there may be limitations in the amount of blood volume that's needed to perform all the testing that may be needed for that patient. Ultimately, these alternative specimen types are not just about convenience, they're about equity and access. Next slide, please. So to address these gaps, molecular diagnostics have emerged as powerful tools. From rapid detection to multiplex testing, these technologies are reshaping how we approach STI testing. So as we look toward the future of STI diagnostics, one area where this would be especially impactful is diagnosis of genital ulcer disease. Lesions can be caused by a range of pathogens, including HSV, syphilis, chancroid, and maybe Mpox. And having a multiplex panel that can detect multiple organisms from a single swab can significantly improve diagnostic accuracy and speed. On the HIV, viral hepatitis, and STI subcommittee, which I chair for APHL, we often talk about our dream panel that we ask for when we speak with vendors. We've settled on HSV 1 and 2 with differentiation, syphilis, VZV, and Mpox. So we'll see if that dream ever does come true. We're also seeing exciting developments in drug resistance testing, particularly for gonorrhea and MGen. While not yet widely available, there are molecular assays that are on the horizon, and will be critical in guiding treatment decisions specifically for MGen and combating antimicrobial resistance. Another innovative strategy is sample pooling, which can be especially useful in resource-limited settings. I show a slide here or image here on the right of kind of strategy of pooling. So you pool all your specimens together into a single test. And then if that pool is negative, you've cleared, maybe 10 to 20 patient specimens. If there is a positive, then you test the samples individually to identify the positive sample. This has its challenges, though, and really depends on disease prevalence. It can work really well in low prevalence settings where the likelihood of a positive pool is low, but then you run into issues with positive and negative predictive values. We're also moving toward integrated testing, where a single sample, whether it's a swab or a blood specimen, can be used to run a panel of tests. This really helps to streamline the workflow and reduces the burden on the patients. So these innovations are helping us move from a one test, one pathogen model to a more patient-centered approach that's faster, more efficient, and better suited to the realities that are public health. On the next slide, I'll briefly describe the approach my laboratory has taken to implement integrated testing at our lab. So we have worked with our public health programs and correctional health to streamline and make it as simple as possible by minimizing the number of specimens collected. We've simplified test orders, reflex from the same specimen. And so here I show a patient's serum and all the different paths that it can take. Traditional HIV testing algorithm. We did previously validate the serum for the HIV qualitative NAT to complete the algorithm. Syphilis, starting with an EIA and moving through that testing algorithm. We offer a full hepatitis panel. And from that same blood specimen, we're able to perform reflex for HCV NAT, surface antigen confirmation, and then a confirmatory HAV PCR, not an STI, but I just wanted to include that one in here to show that we do have that ability. For the HCV NAT, we did a validation to extend the transport time, so we were able to just use that same specimen because all of our specimens come from off-site. Sometimes there's delays. And so we wanted to make sure that we could kind of limit that second blood draw that was needed previously for the HCV NAT. This requires good communication with our providers in order to make this work. It requires good communication with providers, IT involvement in LIMS test build and interfaces, and a very tight lab specimen management system because these specimens are moving around and being tested on different platforms. So it's taken some time, but I feel like we've really kind of mastered this within our laboratory. Next slide, please. In the first session, my friend and colleague, Dr. Tim Southern, covered point of care tests that are CLIA waived and must be performed in a CLIA waived facility like a doctor's office or a clinic. So these are not included here. I'm going to focus on self-collected or tested specimens that are either done completely out of the clinical space, like at home, or tested in a laboratory that's moderate or high complexity. This is constantly changing, so if I missed any, please let me know, but I tried to capture all that I am aware of. I even reached out to my colleague at APHL to see if there was any that I missed, and she kind of helped me with a comprehensive list. But and these are FDA approved. So for self-testing, complete self-testing system that is FDA approved, we've had the OraQuick in-home HIV test for some time. One that I thought is relatively newer is this first to know syphilis test, which is shown here on the right. This is a really cool technology in that the specimen and the test are in the same cartridge. So it's a finger stick blood draw. You tap the cartridge and then wait 15 minutes, like the lateral flow, like you're used to with COVID tests here, and that's all performed within this one cartridge. There's also the VISB medical women's sexual health test for over the counter for CTGC, and I did include the links here so you can access these and go check them out some more. And then on the bottom here, we have home collection where these specimens are collected outside of a clinical setting and tested at a laboratory. These are more recent FDA approvals. The Simpla Collect STI tests by Abbott Molecular was actually the de novo. So this was the first of its kind. This is shown here on the right. So these are the specimen can be collected at home, and then you can get up to 4 STI results: CTNG, TRIC, and MGen. Another kind of new technology is the Teal one by Teal Health, which is a vaginal swab to screen for HPV, which is then sent to a lab for HPV screening. So these are some really neat, innovative ways for testing to be performed at home or to be collected at home and tested at a laboratory. Next slide, please. So as we look to the future of STI diagnostics, self-collection and testing are emerging as powerful tools. And, there are benefits and risks and limitations, of course. So we're all about getting the test to the person, increasing access, enhancing privacy and autonomy by allowing individuals to test at any time. However, there are risks and limitations. So there's variability in specimen collection, transport, and disposal, test performance and interpretation. If you're getting these out to the public, we want to make sure that they know exactly what they're doing. They know how to interpret the test result, so there's no confusion. Reporting for public health, reporting. This is one that we always make sure is at the front and center of our manufacturers so that we can get these results to public health so that we're able to perform surveillance and also partner and contact, reaching out to contacts and partners so that we can do partner therapy as well. So there's tremendous promise in these self-testing test mechanisms, but it's essential that we pair it with education, infrastructure, and policy support to ensure it's implemented safely, equitably, and effectively. Okay, next slide, and I'll get moving because I know I'm at about 20 minutes now. But introducing new public health tests into a public health setting isn't about just having the right technology. We have to be operationally ready. So these are things like getting your lab infrastructure ready for new test modalities. So this is thinking about space for future equipment, staffing, and training resources. One thing that public health labs often communicate with manufacturers is the option for smaller and more flexible kit sizes. This helps reduce both cost and waste, especially in labs that are doing limited routine testing, but may need the ability to rapidly scale up in response to emerging threats or an outbreak in our community. We also face regulatory hurdles like all clinical laboratories. So for self-collected specimens, ensuring that we are able to manage the logistics of people collecting specimens off-site and getting them to our laboratory by maintaining specimen integrity and ensuring proper handling for reliable results. Informatics is just so critical. I think this is just something that previously in labs we kind of took for granted, but as we expand our testing capabilities, we need to ensure our LIMS systems can keep up. So we need to, when we're building tests, think about building reflex testing logic, establishing instrument interfaces for quick reporting, and auto verification to streamline workflow and manual testing, manual errors. So these informatics capabilities are foundational for efficient and high quality testing. They also set the stage for the next piece of the puzzle, which is data integration and reporting. Next slide, please. Oops. So as we expand capabilities and adopt new diagnostic tools, data integration in our reporting systems are critical. Testing alone is not enough. The value of a test is only fully realized when it's connected to care, surveillance, and public health action. So timely and accurate reporting to providers is critical so patients can receive appropriate follow-up, treatment, and counseling. We need interoperability with our public health surveillance systems to allow us to support case investigations and contact tracing, facilitate partner services and expedited partner therapy, monitoring test volumes and case trends, and ensure individuals are linked to care quickly and effectively. And this integration is especially critical during outbreaks where real-time data can guide resource allocation, identify hotspots, and support a rapid response. Self-testing can introduce, like I said previously, new challenges in this space. Many self-test results are not reported to providers or public health agencies, which creates gaps in surveillance and care continuity. So without proper reporting mechanisms, we risk missing cases, delaying treatment, and underestimating disease burden. So we need to invest in data systems that are flexible, secure, and interoperable to ensure that even in a decentralized testing model, that these are connected to the broader public health infrastructure. Okay, so moving on to scaling innovations through public health collaborations. So to truly scale, we have to rely on each other. We need to collaborate together. This is between labs, clinics, jurisdictions, and different sectors. We need strong partnerships between our laboratories and clinical providers. This may include regional initiatives, cross-jurisdictional work. We public health labs are uniquely positioned to be providers of real world data. We get a lot of positives, right? So we have a lot of rich library catalog of specimens, and so these can be used to help support FDA approval of alternative specimen types. However, this process can be very burdensome for public health labs with limited um, administrative abilities here. So due to data ownership, IRB requirements, and coordination between the labs and clinic sites. When we've participated in clinical trials, the data collection is often the limiting factor in us being able to participate. And then the quickie labs, like they've made in New York City, they're modeled after the Dean Street Express Clinic in London, which offer rapid walk-in STI testing with minimal barriers, and then they're paired with accessibility to public health. So scaling innovation isn't just about technology and the new tests, it's about building the right partnerships, infrastructure, and systems. And I think that's about, I just have a summary slide left. So I'm just to so in summary, these are the topics that I talked about today. We can just zoom through that into the next slide. So here's where I believe that that public health labs have a critical role in preparing for the next wave of STI diagnostic innovation by investing in our infrastructure, continuing to build our workforce capacity, strengthening partnerships, which public health is innately good at, streamlining validation and regulatory readiness, and enhancing our data systems for real-time reporting, which will ultimately have an impact on timely diagnosis, treatment, and surveillance. So thank you very much for your time today. Questions will be held, or verbal questions will be held until after our next speaker, but please feel free to use the Q&A to ask your questions. And I'll now introduce our next speaker, Dr. Kenneth Mayer, to present on clinical and syndemic perspectives on emerging STI diagnostic needs. Thank you, Dr. Mayer.
Thank you, Dr. Crumpler, and I'd like to thank Roche and NCSD, Tamar and Leonardo for inviting me to speak to you today. So I'll be giving the clinical perspective, and there'll be some overlap with Dr. Crumpler, but I think it's very synergistic. The next slide, please. So basically, we're dealing with a global pandemic of STI, and although Dr. Crumpler mentioned that there's recent encouraging data from the CDC, we're starting at a very high base, so we're dealing with 1 million treatable STI every day globally. Next slide, please. And so when we think about specific pathogens in the US, if you look at gonorrhea, increasing cases over the past decade and a half or so, and maybe a plateauing now, which is good news. Next slide. And when we think of syphilis, what's particularly concerning from a public health standpoint is that not only have syphilis cases been rising, but the number of congenital syphilis cases have been increasing. And this is in a resource-rich country like the United States, which is really horrendous when we have an outcome that can really have lifelong deleterious effects, and it's a highly treatable disease. Syphilis is still highly susceptible to penicillin. Next slide. And the other issue with syphilis is that it's very much increasingly co-prevalent among people living with HIV who are sexually active. And again, this may create severe problems. People with HIV, particularly if they're not virologically suppressed, who are co-infected with syphilis, can have more serious advanced syphilis outcomes, and this have the impact for their health. Next slide. And similarly for chlamydia, we have been seeing gradual increases, not as dramatic as was the case of gonorrhea and syphilis, but still significant. And then next slide, with regard to gonorrhea in particular, the other concern is that as the number of new infections increases, we're also seeing an increased prevalence of resistance. This is particularly common in East Asia. It's become increasingly a problem in Europe. And this is just an example of the TET gene, which confers resistance to tetracycline for gonorrhea. And close to half of isolates in the United States are resistant. And this is relevant because we do know that there is a means of prophylaxis, doxycycline post-exposure prophylaxis, that can decrease the incidence of chlamydia, decrease the incidence of syphilis. But if it's going to select for more resistant gonorrhea, that's a concern because sometimes these microbes will carry more than one resistance determinant in the same plasmid or the same resistance factors. And that means that by using more tetracycline, we might select for resistance to beta-lactams in theory in the future. So that's a concern as well. So we really have to keep our eyes on the prize, even though the last few years have been encouraging in terms of better control. We're still at a very high plateau, and that's really the take-home with regard to these highly treatable STI. Next slide. So I'd like to tell you a little bit about myself. I work at Fenway Health. Fenway is a federally qualified community health center. Because of the neighborhood it was in and just the circumstances of the AIDS epidemic, it's been sort of a leader in New England with regard to providing care for sexual and gender minority individuals, and particularly HIV community-based care and research. The health center now cares for close to 35,000 patients in primary care. A substantial number are sexual and gender minority individuals. And my role at Fenway is leading our institute, which engages in research, education, policy, and public health work. Next slide. When you look at the patient population at Fenway, you can see that out of a third of our patients are people of color. Substantial number are lesbian, gay, bisexual, transgender, or other sexual gender minority individuals. But in a state like Massachusetts, even with us having healthcare insurance, even before the national health care insurance, a substantial number of people are still uninsured. A substantial number of people are on Medicaid, and this is even greater in other community health centers. And those of you who are frontline clinicians know whereof I speak. So these are very vulnerable populations, but also populations at high risk for STI. Next slide. So when we look at our ICD-10 codes at Fenway, if you look at diagnoses number 1, number 4, and number 10, these are basically sexually transmitted infections. Anal dysplasia and condyloma acuminata, these are HPV-associated infections. And number 4, the ICD-10 code, this is basically individuals who are being treated for STI or for pre or post-exposure prophylaxis. So a substantial infectious disease burden in the clinic, and therefore the need of rapid and efficient diagnostics. Next slide. And what you have is very much a changing environment as well. A number of years ago, it was shown that people who initiate antiretroviral therapy early in their clinical course and are virally suppressed will not transmit HIV. So that led to the U equals U, or undetectable equals untransmittable movement. We also know that one can suppress herpes reactivation with suppressive therapy. So there are these models of chronic disease management, certainly chronic management for HIV, but these are in sexually active populations. So this really requires the need for low-cost point-of-care STI tests so that we can have these individuals be tested and have STIs interrupted, chain of STI transmission interrupted early on. And we want to have different kinds of service delivery models that speak to people who are otherwise healthy and provide them care out in the community. And certainly in the current era, AI tools may be another area where we can use apps or other electronic technology means to be able to improve sexual health for individuals. Next slide, please. And when we think about broader approaches, it's good that we have U equals U and that we have PrEP, but at the same time, these are keeping people healthy who are otherwise sexually active. So this means that very often these are individuals who may have an increased STI burden. So again, these are individuals who in particular may be high frequency users of STI services. So having state-of-the-art diagnostic technologies is really important. And that's where the role of rapid point-of-care testing comes in. Next slide, please. So another intervention that I mentioned briefly at the beginning is the whole issue of doxycycline post-exposure prophylaxis. So this is giving individuals prescriptions for doxycycline that they can take 200 milligrams after a high-risk exposure. And you can just see the chart. First papers that suggested that this might be useful were in mid-2022. It took a while for the diffusion of innovation, so we didn't start having patients on doxycycline post-exposure prophylaxis till February, but now we've continued to have individuals. This graph only goes through last year. We've just tabulated our data over the past year, and at the present time, we've had about 2,500 individuals who've received a prescription for doxycycline post-exposure prophylaxis. But these are individuals, by definition, if they're exposed to STI, also are candidates for more frequent STI screening. So this, again, is another a part of the population where we have the need for rapid point-of-care testing. Next slide, please. So the public health challenges are that we have these rising STI rates, high levels of STI rates, and they constrain the healthcare system. The actual medical costs for gonorrhea, chlamydia, and syphilis alone are over $1 billion a year. But if we rely on centralized labs, there's several days turnaround. So this means that very often, if somebody comes in with a drip or a sore, we're treating empirically, and that may not be the best antibiotic stewardship because oftentimes there's a differential diagnosis, and we may not always guess right which pathogen we're treating for. If the individual has to come back for a test of cure or doesn't get treated but is asked to come back, they may be lost to follow-up, and during that period of time could potentially transmit an STI to others. And certainly this is less efficient for partner notification. Again, the current system as it is not conspired to optimize public health approach to STI management. Next slide, please. So there are challenges, particularly the other thing, and this was embedded in what Dr. Crumpler was talking about. We have a large number of pathogens, and if we try to diagnose each pathogen separately, it's a variety of different kinds of assays that we might potentially use. You know, we're doing serologic assays for syphilis, but if the differential diagnosis is sore, we're trying to think about HSV2. Are we going to use a culture? Are we going to use a NAT test? So a variety of pathogens. And what I put in bold, these are all organisms for which there are molecular tests available currently. And increasingly, these are rapid diagnostic molecular tests. So for the majority of the organisms on this list, a large list, we can actually use point of care testing in the future to make diagnoses, to make more efficient diagnoses. Next slide, please. So with regard to these clinical challenges, I do a lot of teaching with clinicians, medical students, fellows, and a lot of people think that, gee, if I test the urine, if I test cervical secretions, I've done my job. But very often these pathogens can be extragenital, and particularly for chlamydia and gonorrhea, they can be asymptomatic in many individuals, but there may be isolated pharyngeal or rectal gonorrhea or chlamydia. So we really have to be able to test all three sites. And again, as I mentioned, doing the differential diagnosis may mean multiple lab assays for the same lesion or the same discharge. It's much more efficient if you just use one test and test for multiple pathogens at the same time. The other thing is that we're looking for tests of cure. If you've knocked down the number of organisms, but you haven't totally eradicated the infection, if you don't use a very sensitive assay, you may be missing organisms that may regrow at a later point in time. So NAT really is the answer to many of these concerns because you can use the same specimen for multiple pathogens, and it's very sensitive platform for low copy numbers of organisms as well. Next slide, please. So the role of molecular point of care testing and how it manifests, as you already heard some, you can get a rapid test sometimes as quickly as 20 minutes, certainly 80, 90 minutes would be outlier in terms for many of these platforms. Most of these platforms can diagnose multiple organisms. This will allow for same-day treatment. It will give a specific diagnosis, so one is not treating empirically, which allows for better antibiotic stewardship, more efficient for partner services. And it may be better for the user to know exactly what they have and to focus on the specific infection than to say, come back again for another test, or to the test we sent didn't show what we were looking for. And again, it also may allow for more efficient workflows. Next slide. Um, so one of the other issues that we have to think about, though, is that the tests don't take themselves, and um, there are issues from the lab perspective that Dr. Crumpler talked about, but they're at the clinical end. We obviously have to think about staff training. Clinicians need to know how to put the swab, what are the characteristics in terms of leaving the specimen out, um, um, stewardship of the specimens. One needs to have a level of training that can pass CLIA certification. Certainly quality assurance measures have to be in place. This may mean changing clinic workflows because different people may be doing different assays, different parts of the system, and certainly linkages with public health reporting, as you heard, and for surveillance. And funding is always the big issue, and it's not consistent. We don't have a very consistent healthcare system. Certainly, it's a very tumultuous time for healthcare, but there are some early models that are exciting. Medi-Cal is looking into how to support innovation, and there's a 340B clinic in Florida that is a role model, and this shows promise. Just to tell you a little more about that in the next slide, with regard to Medi-Cal, there is a separate code for same-day molecular point of testing and a reflex test that they've set up. So this is highly innovative because the cost issues are kind of funny depending on how you approach it. I mean, most of the molecular point of care tests are more expensive, for example, than an antigen test, but their sensitivity is better. So there's a trade-off there. And then if one is relying on an external lab, that lab may be much more expensive. So the molecular point of care test can actually be cost saving, but again, it has a lot to do with the volume and the experience of the center that's doing the testing, and certainly the startup costs for the machines, et cetera, and the consumables. Another case in point example is that one clinic in Florida, nonprofit clinic, has developed a model very similar to the Dean Street walk-in clinic in London, where people can come in, get tested with molecular point of care testing, and get a result in less than 20 minutes. And they've gotten the cost to less than $40 a test, and they've been able to get payment under the 340B program. So there are innovative models. There's not a consistent program across the country, but we are in this interesting time where these things are evolving, and I think paying attention to the innovation and lessons learned, I think, is going to be important going forward. Next slide, please. The other thing that we have to keep in mind always, where my hat is training people up, and so that does mean that it will require any clinical center to have somebody become a medical director and develop quality assurance protocols and SOPs, and then obviously paying attention to the package insert. That will involve lab training. People will have to be comfortable with the result delivery. And certainly there always are indeterminate outcomes in any assay. So that's important as well. And then, ensuring that the systems are in place for same-day treatment and smooth referral and the linkage to the electronic health system. That's going to be extremely important as well. Next slide, please. And from a patient standpoint, and this ultimately is the most important thing, this has really great potential because one could make a diagnosis the same day, and this would allow for specific counseling, potentially fewer visits. So one could ask the patient to wait, go get a coffee, come back, have the result, get treated, all the same visit with a very specific diagnosis. In terms of expedited partner therapy, particularly if people are meeting casual partners, it may be easier to track down a casual partner like you've seen the night before than to find somebody 3 or 5 days later. There are also some opportunities for innovation in how care is delivered. These assays could be done in mobile units, could be done in drop-in centers, so that would make things more accessible to populations who are not necessarily going to come into the center of town to a clinic. Some of the platforms are amenable for self-testing as well, and this may also allow for opportunities in terms of test of cure, other opportunities for innovation. The next slide, please. So with regard to all of these issues that we've been talking about today, the STI overall, if you think more over the course of the decade, they have been increasing. They're at a very high level, and they're more of them that we want to intervene on. So these are management issues for healthcare workers. The molecular diagnostics can improve patient care, but there's still a lot of logistical issues, certainly including workflows and reimbursement. But we will continue to learn from innovators and continue to learn about best practices. And certainly it's not a question of whether we're going to do it, it's a question of how we're going to do it and when is the system going to be ready to do it. With that, I'd like to thank you, and last slide, thank everybody for your attention.
Thank you so much, both of you, Dr. Mayer and Dr. Crumpler. That was really phenomenal. Excellent presentation. Now let's open up floor for the Q&A section. If you have not submitted question yet, I just see a few of them already. Please do so. So the first question is there any testing technology in the pipeline to replace the PRP that could be used to properly stage a syphilis infection? Maybe I'll start with Megan.
Hi there. Is the question is, are there tests in the pipeline for staging syphilis?
Is there any testing technology in the pipeline to replace the PRP that could be used to properly stage a syphilis infection?
There are, but they're far away in the pipeline. I don't think we're really that close yet. There's some different technologies. I just saw Dr. Jeffrey Klausner from UCLA speak this week, and he's talking about some technologies for replacing RPR that are based on different either like biomarkers. There was one that's in development that's like specific for the peptidoglycan layer within syphilis. So it's definitely something that we need and want, but we're not that close, unfortunately. We're stuck with RPR for hopefully not another 100 years, but some more time. I don't know. Dr. Mayer, do you have any other insight into that?
No, I exactly what you're saying. And Jeff Klausner is certainly one of the people at the cutting edge. There are people working on it. But I do think I am excited, though, about the various multiplex NAT testing for primary syphilis. So I think certainly for lesions, we can do a really good job of diagnosing syphilis now and don't have to rely on serology. But certainly for later stage, it's tricky. But certainly some of the NAT platforms plus serology can help give more precision, but it's still not exact science as much as we'd like.
Yeah, and in our clinic and our public health lab, because we are co-located, we still offer dark field microscopy, which is our STI controller, orders frequently, and we have frequent positives, but again, old methodology. So we are looking forward to some NAT for the genital ulcer disease.
Great, thank you. I think I'll start with Ken, the next question. This presentation really highlights, I think it was referred to your presentation, Ken, the number of new advances and technologies available to testing and treating patients. I'm curious to learn more about what strategies are the most effective in supporting the adoption and integration of new diagnostic tools within existing healthcare system.
It's complicated to answer because my answer would have been different maybe about a year ago. So the CDC has funded prevention training centers, and to the best of my knowledge, they're still in existence. But obviously, the current environment makes it very tough. But there are some really wonderful leaders in SD work around the country who are at these regional centers that often are affiliated with public health programs. So there are these great training resources. So if you keyword, if you're in a jurisdiction where you could keyword prevention trainings, STD prevention training center, and you could see where's the center in your jurisdiction. So for example, in Massachusetts, we have a wonderful one run through our state lab. Thank you. Allison put in the website. fantastic because the prevention training centers, I think, are the best resource that people can have. They offer courses. There's a lot of technical assistance. So I know in Massachusetts, that's really our great resource.
Thanks, Ken. Anything to add, Megan?
No, nothing to add there.
Yeah. So we only have a minute, so we have one more, question. Maybe time for one more question. Can you talk a bit more about the quickie clinics? Does it involve in appointments or quick turnaround of results for treatment or both?
There's not like one single model. They're different. There are different places that have different models. I mentioned in the talk, but one thing you could Google, because I still think the video is probably accessible. Dean Street is it's a clinic in London. It's in Soho House. It's near where there are a lot of gay bars, a lot of adult entertainment venues. And they sort of had a regular bricks and mortar clinic, and they said, gee, with all the new technology, we could really scale this up. So they created sort of this modern interface that there are a number of centers across the U.S. that have created where you walk in, you touch through a computer interface, you input your information. It'll tell you what tests you need. You can go into a room and there's a video that'll show you how to self-swab. And again, the turnaround is 90 minutes or less. So that's kind of a role model. But there are other places around the country. Magnet Clinic in San Francisco has adopted that model. And I think in many major metropolitan centers. Yeah, Leonardo just put in the Dean Street website. So I think these are really good models. A lot of this, has to do with kind of the volume at a center that you anticipate and the ability to get dedicated resources. In the prior world that we were living in, both the CDC and then a number of state health departments would fund innovative model programs. So to what extent that's going to be feasible going forward, it's hard to know. But there definitely are these best practice models to look at. And again, I think one of the take homes is one size is not going to fit all. For the time being, there are a number of different platforms that are being investigated that Dr. Crumpler can speak to, but there are a number of clinical sites. And I think we're all in this together. So people like each other coming to visit, so many of us have made the pilgrimage to Dean Street to see what lessons learned that we can adapt for our own clinics. And I think that's the way forward.
Thank you. We actually are a little bit over time, so we'll close this session here. So many thanks again to our wonderful speakers, to NCSD, and of course to all of you for joining and contributing today. So, and we truly appreciate, the time, but the dedication more so, and really looking forward to staying connected. Thank you all.
Thank you.
Yeah.